Myself, Jamie Count, physician assistant with Gardner Webb University, here today to take a look at you. Is that okay as a student if I take a look at you?
Yes.
So she gives me consent to do that. And so I get her name and date of birth to make sure I'm in the right room.
Anna Macaluso, 11/10/98.
Yep, Pillow's older than you. And so let's see here. So I make sure the lighting is good in this particular room. And then I would make sure that I have all my equipment, my ophthalmoscope, everything that I'm going to need to do the exam. So, with that being said, we'll get started.
Test visual acuity, cranial nerve 2, verbalizing one eye at a time in both eyes. Should alternate left to right to left when switching eyes.
Okay, so you guys have done this, so that's where I would take that card. I would hold it. Remember, my little golden rule is if you were beside the patient, 1, 2, or go get Hayden and have him lay down. So you hold the card up and say, okay, cover one eye. If you want to do it with her corrective lenses on, if there's a reason you need to do it with them on and off, then that's fine. For this purpose, we want them one or the other, it doesn't matter, and then both eyes. So you would hold a card and say, read the smallest line you can from left to right, and she would read it. Okay, uncover that eye. You allow that eye just a little bit of time to focus, because sometimes you cover one eye and then you open it up, it's kind of like, okay, a little blurry. So, okay, tell me when you get your focus back. Are you good? Mm-hmm. Cover the opposite eye. Read the smallest sound you can from right to left. So then she would do the smallest line from right to left. Notice I didn't say read the same line or read the same line again or any of that type of stuff. Smallest line from the opposite direction, okay? If you can, uncover that eye. Let me know when you got your focus back. Good. Okay, with both eyes, can you read the smallest line you can from left to right? Notice I went back to my initial, and then she would read the smallest line she can from left to right, and you record that, okay? OD is right, OS is left, OU is both eyes, for what it's worth, okay, in medicine, okay?
Okay, yeah, so you would verbalize with test with or without corrective lenses, inspects the eyebrows and eyelids, noting symmetry, erythema, or lesions.
What was that E word?
Erythema.
Is it M-I-A or M-A?
E-R.
What? Isn't there 2 R's in it?
I'm giving you a hard time because I can't pronounce either. It's erythema. If it had M-I-A, it'd be erythema.
Okay, erythema.
There you go.
Do I need to take off my glasses?
So, you have her take off her glasses.
Blind.
Alright, so that being said, I've already lost mine.
Okay. Inspects eyebrows
So
and
look
eyelids.
at eyebrows and eyelids. So look, you're looking to make sure they're continuous. You're making sure symmetric. They're not thinning. Now remember, some people will cut their eyelashes, those types of things, just like tattoos or anything else patients may have. So if it's something intentional, you can just denote the patient grooms eyebrows or something like that. She doesn't. And so can you close your eyes and just leave them closed so I can look at her eyelids. They're awful twitching right now. Just relax them. So I can look at her eyelids. Okay, you can open your eyelids. And then just noticing her inferior eyelid too. There's no like perioral swelling. There's no ocular shiners, any of those types of things that we use in medicine. Okay? Eyelashes as well. So notice her eyelashes. She obviously uses a little bit of mascara. The eyelashes are spread out. They're not sagging. They don't have any crusting on them. They look symmetric. Both sides are not thinning. There's not extra ones that are filling in, and so all that looks normal.
Inspects and palpates the lacrimal apparatus.
So apical lacrimatis just kind of come right over here near the orbital ridge and push up. You shouldn't feel any swelling. There shouldn't be any tenderness. And then we'll go to the lacrimal sac and kind of push right here to make sure I don't feel any swelling or any type of inflammation or see any type of discharge.
Inspects the conjunctiva, noting injection or lesions.
So it's important here to look at bulbar versus your palpebral conjunctiva. So I can pull down on her eyelids. Now I don't want to like yank way down. I just want to pull enough to where I can see them and I can see the insides of it. I can look at the bulbar and palpebral. So can you look up? Look to your right. Look to your left. All right, and then you can go here and say, okay, can you look down? That way I get the superior aspect of that. If there was a reason I needed to see the top underneath kind of the eyelid, I could take a Q-tip and roll it out. Kind of how when I was little we made like, well, quote unquote, little devil eye, like you roll it out and you look all creepy. But there's no use to do that for this exam, okay?
Inspects the sclera, noting color.
So I'm looking at her sclera. Here again, it's good to note the color of sclera. So look up, look down, right and left, and noticing that it's white continuously throughout. There's no yellowing or scleral coloration that we would see there, like sclera icterus.
Inspects the pupils, noting size and symmetry.
So at this point, I can take my gloves off because I'm not going to be any no longer near the eye, okay, as far as touching that I know of. So I'm just going to look at her pupils without the light, just to look straight ahead at my nose, and they're both the same size. They're kind of mid-dilated in this particular room. They're not pinpoint and they're not ultra or extra dilated, so that's good.
Uses oblique lighting to inspect the cornea.
Okay, so what that means is look straight ahead as if you were looking at Nia. And so basically what you get my right light here. So I want my middle light, and then I want to get off my color. So you look straight ahead, and what you're going to try to do is just look at the side of the cornea. And what you're doing here is looking for the topography. It should be smooth, it should be convex, you shouldn't see any rippling or any type of defects there. So when you get to the side, you're just trying to look to make sure the eye goes symmetrically around and there's not any type of abnormal topography.
Sorry, you asked me to stop. I'm trying to see.
Oh, I'm sorry. I thought you said count. Okay, go ahead.
Test direct and consensual light reaction, cranial nerve 2 and 3.
Okay, remember this is our swinging flashlight, so some of this is repeat, but it's good for practice. And so just look straight at my nose, don't pay no attention. All right, you can see her eyes constricted. I take it away, it dilates back. I don't want to look at this eye anymore. I just want to make sure the light gets there. I'm focused on this eye. It constricts, take it away, it dilates back. Okay, swinging flashlight, and then you do that on both sides. Because the signal going in is afferent, efferent, and then when I go on this side, signal going in is afferent, efferent. Okay?
Test accommodation by pupillary constriction of
Now this is the one, remember I said it, everybody in here hears me and you got me recorded. Okay? This will not work. Okay, watch my finger. Students do that all the time. There's no way, guys, you're not going to be able to see it. Take your time. Goes in, they got small, and as I go back, I'm going to watch for them to dilate back. And they did. Okay? Take your time. I'm also noticing convergence as her extraocular motion come together and back out. Together.
Test EOM in the 6th cardinal position of gaze.
So remember, oh, go ahead.
I was just cranial nerve 3, 4, and 6.
So remember, there's no need to do this. No, just go to where she maximally can go, and then go up, go down, over, up, down, and usually what I'll do is then is when I'll do my accommodation convergence. Because it's part of that whole movement and it's just continual and it knocks everything out and it's got a nice little flow to it.
Test visual fields by confrontation.
Please pay attention. Okay? You don't mind if I get close to you, right? I got going. Okay, good. This needs to be kicked in. And so the key here is when you get here, if I start here and I say, okay, cover your right eye. I cover my same eye that I would be seeing that particular visual field in, okay? So since she's using her outer lateral eye, I use my outer lateral eye. The key here is if I start here, can you see my hand?
Mm-hmm.
I can too. We have proved nothing. Our peripheral vision is always working, okay? So what you gotta do is get close enough to say, okay, can you see my hand? Look straight at me. My fingers. Can you see my fingers?
No.
moving? Me neither. So what I do is slowly come in and you tell me when you can see them. Twinkling.
Probably no.
Me too. I can too, okay? Well, that's what you're doing. You're comparing it to yourself, okay? And then stay here. You're going to do the same thing down here. Same thing. Can you see my fingers? Well, I can, so I need to move to where I can't see. Can you see my fingers?
No.
Well, I'm moving them. Can you see them?
Yes.
Can you see them?
No.
I can either. So slowly come in to where both of you see the finger twinkling. Okay? Me too. Now here's where it gets tricky. Okay, I want you to stay there. Okay, but now I've got to cover that same eye with this hand because I'm coming from this field. We're testing all 4 fields. Okay? If I stayed here, I'm not going to do like this. Okay? So just put this hand over the eye, and there's no need to go way out here. All right? We can't see right here. You're wasting your time. Come here and say, okay, can you see my fingers twinkling?
No.
Me neither. Now you can? Good. And so you do that from 4 regions. So start here and come across. Start here, come across. Here's where patients, and Professor Shamlin may get on to me about this, but her neuro and me doing this are somewhat, maybe a little different, I don't know. But do not do this for this class. You get a little bit more advanced, we're going to change it. What? Do not do this. Can you see it? Can you see it? Can you see it? Because that's what students will do. You can't pick up when that came in because you're moving 100 miles an hour. What point did they see it? Because you're comparing their eye to your eye and when you first saw that peripheral field, right? So I want to see slow. Slow, okay?
Performs cover and uncover test.
So for this, you would get some type of card. Let's just say they had a eye here that seemed to be not working right. Let's just say it's the left eye. It's not working right. So I'm going to cover her strong eye and see if this eye deviates back to or aligns. And then I can uncover and see if that eye goes back to a position to where it's not working because the strong eye is taking over. Cover the strong eye, make the weak eye work, and see if it moves. So cover, uncover test.
Fundoscopic realizes I would dim the room light before the fundoscopic examination. Uses right hand and right eye for patient's right eye, opposite when done on left.
All right, remember, I teach you guys Mike Tyson tattoo, and that sounds funny, but you guys are going to remember that because that's where his tattoo is. On the side of his face, remember it, my hand to her eye that I'm evaluating. Ophthalmoscope hand to eye you're looking at. It would be awkward for this because then me and Anna's going to have an encounter we don't want. Okay? Stay over here. Your mouth, her mouth stays away from each other. Okay? So, the first thing you want to do, remember I told you, retina, is it far off or is it an anterior or posterior structure of the eye?
Posterior.
Posterior, far off. So we need to get about 10 foot away. I'll look at those nitro exam gloves. I say, okay, at what point do they become really in focus? Right there. So that is a -1, and that's where I'm at. So I got my focus on something far off because I'm looking as if it's a far off back structure of the eye. I put my hand on the head, I get 15 degrees. I do not want to be here saying, Anna, look ahead. This is 45. 15 degrees. I want you to look straight ahead at Nia. She's your best friend. All right? So I get the red reflex. I see it. As I come in, it's important, if you watch my light, it stays in the center of her pupil until I get in close enough that I can actually see the structures in her eye. And there's her optic disc. We're all kind of in an optic cup, and you can see the vessels. Try not to stay here too long. Look into the light. You try to look in the light really quickly, and you pull back, looking for the macula and the fovea. Remember, it is your mid-grade light, and it is not totally dim. It is not totally bright. You want to dim it just a little bit. And you want to have the door almost completely shut because you want those eyes to dilate up so that light can hit more of the retina, so you're going to be able to see more of what you're looking for. And then you're going to voice everything you voice about. Looking at the arteries, the vessels, looking at the health of the retina, looking for any type of AV necking, any type of hemorrhaging, that type of thing.
Yeah. I think this is for program. Yeah. I think you covered everything.
All right. Questions?
You have to do both eyes when you do, or we're just gonna.
I would practice, but when you're on the exam, you got to do both eyes. So I know one's going to be a weaker eye. My right eye is a weaker eye, even though I'm right-handed. We have Professor Shamlin, and we have Dr. Clark.